Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone, and welcome back to another episode on the Health Trip Podcast. Today, my guest and I are tackling an often overlooked but essential topic for women's wellness and longevity, sexual health and intimacy in midlife and beyond. Many women struggle to discuss these changes with friends or healthcare providers, yet they play a crucial role in confidence and pleasure. We're going to dive into the impact of hormones, particularly testosterone, on libido during midlife and beyond. Additionally, we'll explore vaginal rejuvenation therapies, their benefits, and how they enhance comfort and intimacy. Plus, we'll discuss tools like vibrators and other strategies to reignite passion and connection. My guest today is Dr. Samina Rahman. She is a board-certified OBGYN, sex med gynecologist, menopause specialist with an academic affiliation at Northwestern University Feinberg School of Medicine. She is also the founder of the Center for Gynecology and Cosmetics, a successful practice in Chicago that emphasizes evidence-based medicine. Dr. Rahman is dedicated to evaluating and treating each patient with compassion, trauma-informed care, and an awareness of personal bias. Additionally, she hosts the podcast Gyno Girl Presents: Sex, Drugs, and Hormones. A quick medical disclaimer before we start our podcast. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dive into midlife sexual wellness for women. Hey, Dr. Samina, welcome to the Health Trip Podcast.
Thanks so much, Jill, for having me. I'm so excited to be on.
Yeah,
I know
I'm excited.
It's been like months in the making.
I know, right? I'm so glad we get to connect, and we're in the same town of Chicago.
I know. Hopefully we can get a meetup together soon.
Yes. I'm excited to have you on today because I think women in midlife and beyond really need help in terms of finding their groove back to their sexual pleasure, or even for the first time discovering pleasurable sex.
Yeah, absolutely. I mean, this is a big issue that most women experience at some point in their life period, but in the midlife, it's accelerated for sure.
Yeah. Let's first set the stage for women's sexual health in midlife and beyond.
Yeah.
What are most women going to experience?
You know, most women will experience some form of sexual dysfunction. The biggest thing that we see for most women is really greater than 40% might experience low libido with bother, which is hypoactive sexual desire disorder. That's where you want to have sex, but you can't. And so that's one of the biggest things I think that either, for various other reasons, we know our biochemistry is changing in the midlife. We know hormones are changing. We know midlife women carry such a burden on their shoulders, right? Like some of them are at the pinnacle of their career. Some of them are dealing with older parents. Some of them are dealing with kids. Some of them are dealing with divorce. Some of them are dealing with death. And so you have a culmination of, I call it the perfect shitstorm of events happening, which is really like a lot of life stressors that women bear the burden of. And then on top of that, your hormones are going haywire, right? Like your ovaries are going out with the fight. Like they're not going to retire just like silently. So, you have all this. And then, of course, the whole idea and around wanting to have sex is not there for so many people. And for some people, it's totally fine. Like the low libido is just like not bothering them. It's not bothering their significant other, and they ride it out. But when you have a discordance or you feel bad about, I have patients that feel dead inside because they don't have that that light that they used to feel like, or they don't feel like themselves. And that really provide that intimacy with that special person really provides them so much comfort and joy and satisfaction and really just life changing for them. So that, and then along with that, we have so many women that I think it's by the 8th year of postmenopause, most women, some of their 8th year, you get like 70 to 80% of women getting the genitourinary syndrome of menopause, which includes painful sex for so many patients. So it's where you have a change in your vaginal and vulvar um, organs. And so the architecture of your vulva might change, your labia might disappear, your clitoris might shrink down, the vagina actually will shrink as well because really just dictated by the fact that you no longer are producing estrogen and that 50% of your testosterone is diminished as well. And so both of these areas of your genitalia really need and thrive on these hormones. So when it's depleted for so many women, it's not just vaginal dryness, it's urinary frequency, it's urinary urgency, it's urinary UTIs, and then painful sex. And so with that, then will come pelvic floor dysfunction and a host of other issues. So the combination is really problematic for a lot of women. So, of course, when we talk about low libido, it's really a matter of, okay, if you're having pain, if it feels like sandpaper, if it feels like glass, like cutting you every time you have sex, you're not going to want to have sex. So that's a different scenario than someone who authentically just has low libido with bother and all the other parameters are okay. So you always treat that aspect and then work on the low libido with bother or the hypoactive sexual desire disorder.
Yeah, coming from the lens of a health coach, I can also say that a lot of women during this time are experiencing weight gain around their midsection, hair
Absolutely.
loss, skin changes.
Yeah.
Like we're going through all these physiological changes. I mean, that was my story. I was
Yeah.
in perimenopause. I've been on a hair loss to hair growth journey for 27 years, but it really
Mhm.
resurfaced in perimenopause. And I was also going through a divorce at that time. So I have my hormonal fluctuations, I have my emotional state, my
Yeah.
divorce going on, my kids to
Yeah.
worry about, my hair's falling out. Like,
Yeah.
it was really, I had
Yeah.
no libido. I just
Yeah.
zero desire.
Right, the body image factor is huge, and
Yeah.
and so because for women, it's so multifactorial, it's just not biology, it's just not depression, anxiety, and the psychology, and it's just not your social aspects, it's all of it at once, so I think that's very important to remember as well. Yeah, I just spoke to Dr. Omar Ibrahim on my podcast a few weeks ago and just posted about it, but he's an amazing, hair, loss expert, and so we talked a lot about that, but it is a
Yeah.
huge issue, actually.
Yeah, absolutely. But so besides these symptoms that you're talking about and these changes that we're going through, what are some other related symptoms or issues? Like I've heard things about the vulva and the clitoris nerve endings becoming dulled during this time.
Oh, sure. We have to remember that as our vascular flow, as the blood flow to this area diminishes, because estrogen is such like it really promotes good growth. Estrogen and testosterone promote good blood flow to the area. That your nerves need that blood flow, and so some people are so excited about the number of nerve endings in the clitoris. But you have to remember when there's that many nerve endings, there's that many issues that might come up for them to get dull because they're smaller. It's a smaller vessels, it's smaller nerve endings. And so people do have issue with, the intensity of their orgasm changing. Some have a blunted orgasm, some have no orgasm. Sometimes arousal becomes a problem. And, like women are 4 times more likely in midlife to get treated for depression and anxiety with SSRIs, right? So these antidepressants are such a huge driving force for so many women to have sexual dysfunction too. And they're sometimes never even counseled on it. Like, hey, you know what? Your arousal might change, your orgasm might change, you might have no more desire because of this SSRI, not to mention your bone density. So, I mean, I feel like there's so many issues that really get affected when we even start medicating patients for, symptoms that are related to perimenopause and midlife.
I think that's a great segue into talking about hormone or menopause hormone therapy
Hmm.
and is specifically testosterone. I
Yeah.
know that when I went on hormone therapy, it was really helpful to me. However, it doesn't come without risks for people. And for me, it triggered more hair loss in terms of having too high of DHT levels when I was taking testosterone. And so I want to kind of dive into that side of testosterone of who's a good candidate for, like, the spotlight is always shining on estrogen and progesterone, but I want to dig into
Mhm.
testosterone for a little bit here with you.
Yeah,
This is something that I'm so glad is being brought to the table and starting to show up more on social media for women to learn about and become more comfortable listening to
yeah,
conversations around testosterone.
yeah,
So just give us the lowdown on testosterone and why this
yeah.
is so important.
And I think this is great because, I'm part of the International Society for the Study of Women's Sexual Health, which is ISHWISH. And,
Yeah.
I want to say it was like 7 years ago when the guidelines came out for testosterone. It was like 2018 or something like that. That's when we knew. And so that's when I started introducing testosterone to the picture. And women were so terrified of starting testosterone then, like, oh, why would I do that? I'm going to grow a beard and, all the things that you think about. But what we know is, strictly by our guidelines and by our data, we know that there's great data to support that a lot of women who suffer from hypoactive sexual desire disorder, that I want to have sex, but I can't, the low libido with bother, they do really well with testosterone replacement. And so it's very difficult to replace a woman's testosterone because we don't have an FDA approved version, right? We don't have a government approved version of testosterone for women in the United States or any country except for Australia. And so, what we have to do, and there's 31 different types of testosterone for men, by the way.
Really? I did
Yeah.
not know that.
Yeah, and so, what we have to do and what I usually do is, we prescribe, an FDA-approved male testosterone and titrate it to female dosing, so 1/10 the dose. So our goal is always, okay, if someone comes in at low libido with bother and, maybe they have fatigue and they're concerned about their muscles and all these things, but their main concern is really that
Mhm.
hypoactive sexual desire. And, who's I'm not saying that there's not other benefits of testosterone, but my
Right.
driving force when I prescribe it is really trying to stick with the guidelines, which is this is where I've seen the benefit. And patients, of course, tell me, you know what, I'm thinking faster, my concentration's better. I feel like when I work out, my muscles are, getting more developed. All of these things can happen for some patients, but our goal is to replace testosterone to premenopausal levels, right? So we do, that's the one time where, getting your blood work is helpful. And so we will obtain your testosterone levels at a baseline and see what it is. And then if it's in the low range, then we will, then work toward replacement. Because what we know is testosterone levels, when we check them, don't always correlate. Like I have patients who have like something like polycystic ovarian syndrome and they have a lot of facial hair loss and acne, but maybe don't have reflected in their blood work. And the opposite is also the case. They might have PCOS and have none of the high T symptoms, but their blood work is through the roof. So, it all depends on your receptor activity and how you're able to bring this hormone into your tissue. And so that's why it's so variable. And I think that the levels don't always coordinate, but our goal is to keep it in premenopausal levels so that you can be that's the safest thing, right? Because what we know is when you get super physiologic, when you get too high, you do run into the consequences of hair loss, acne, facial hair, and then these other conditions that are not reversible, like enlarged clitoris. I've seen many women, I have many, patients that come to me and they, maybe they're out in California and they're 30 years old and they got pellets and they come to me with micro penises, which they had never that wasn't their goal and they were never counseled on that. And I can't do anything for them because there's no way for us to necessarily reverse it. The same thing about that deep voice, that manly voice that some people get. And we think it's really correlated with super physiologic levels. So, that's why we watch the testosterone for that. But everyone's receptor activity and activity around their levels is different. So there are people that sometimes are in normal range but still experience hair loss or a little bit of acne here and there. And I think it's just it's patient dependent, but we think
Yeah.
that the safest thing is to keep them in the premenopausal range.
Yeah, I would agree with that. Although there are some women, and maybe some women listening to this right now, who are on pellets and they're
Yeah,
really doing well with pellets.
of
So
course,
I do
of
think it's
course.
definitely individualized, but I would say
Absolutely.
I always say don't start with the pellets. Start low and slow and work
Yeah,
with a provider who's really well versed in testosterone,
right.
because I did start with pellets over 10 years ago.
Uh-huh.
And like I said, my levels were in men's ranges, and it
Sure.
triggered massive hair loss for me, and it was a
Yeah.
long road coming back from that.
Yeah.
So yeah, low and slow is definitely the strategy to go.
Totally agree. And I don't demonize women that, like are choosing pellets. I mean, the reality
Right.
is we have a deficiency in clinicians who are willing to help women with hormone therapy. So we do have these predatory markets that develop because people are not doing things, that are within the guidelines. But I understand too, because like first we don't have that many options for women, right? We have to do this weird alchemy and say, use this pea size amount on the back of your thigh once a day, or take a syringe and make a 5 cc syringe out of each tube and you titrate half a cc a day and rub it on your. I mean, like, in what world is that like?
Right. Right.
Right. But I think that, we have to do what we can, and hopefully we'll have a government approved testosterone at some point. But again, like, I have definitely patients who come to me already on pellets, and, we try to get them on something that's what we think is a little more safe. But, some people, you're right, they do well on pellets. It's not something I personally do in my practice, but I don't
Yeah.
demonize it either.
Is there is it an option to only use testosterone and not be on estrogen or progesterone?
Sure. Sure, I definitely like, there are patients who, that I see oftentimes who are like 10, 20, 10, 15 years past menopause, and they never had significant concerns. Their bone density is fine,
Mhm.
like, they're not concerned about all of these other parameters, but their biggest issue is that ridiculously low libido, and they can't, improve it. And I've placed patients on it, and they're like, "Oh my god, I just weird, like my brain fog is gone," or, like my
Mhm.
muscle, and we always worry, like, once you get past menopause, that your ability to maintain good muscle mass is going to decline. But I think that, some people, are able to rebound in that capacity. But I do have patients that are just on like testosterone and vaginal estrogen because sexual concerns are the biggest ones.
Is there anyone who's not a candidate for testosterone therapy?
People that have, uncontrolled lipid panels, right? Like, so if you're hypercholesterolemia, if
Mm.
your cholesterol is too high and you don't have a treatment for, like, I mean, definitely, I mean, that's, per our guidelines. And then, these end stage liver issues around liver function, and those kind of, and some of the cancers, there's some debate around whether or not like cancer survivors should be on, testosterone. But we always, it's a person to person, like, really precision medicine is what I call it, when you really take a person as a whole and look at all their
Yeah.
genetics and all their history. And but those are
Yeah.
the big ones we consider, like someone that has like triglycerides through the roof and they're not on any treatment and they have no desire to be on any treatment, or whatever the case may be. We
Right.
worry about some of those things.
Yeah. And
Yeah.
so for the person listening who does not want to use testosterone, they don't want to use any type of menopause therapy, do you suggest any non-hormonal options to them, and what would those be?
For the low desire, low
Yeah.
libido level. Yeah, I mean, there's plenty. I mean, treating sexual dysfunction is a biopsychosocial model. So sex therapy is huge for these patients, right? Like, I work with some great sex therapists. They really do help bring patients forward.
Yeah.
There's an app called Rosie that really has
Hmm.
helped a lot of patients with low libido. And then we have FDA approved medications that are approved for premenopausal women, but there's data that shows that they work in the peri and postmenopause too. So although they might not get the medications covered by insurance, they will. It is an option, and I tell them it's off label. I'm telling them that it should be safe for them. We don't have any reason to believe it's not, and so we will work with those. And those are the medications that work on your brain, right? I always talk about the brain as our biggest sexual organ, and so there are things that will put our brain into sexually like excitable mode, and things that will inhibit our brain into sexual activity. And the hormones like testosterone and oxytocin are those. And then there's the neurotransmitters like dopamine and norepinephrine. And so when we have those neurotransmitters increasing over time, that will help. So something like Addyi, which is flubanserin, it's a medication that you take every night before you go to sleep. It helps some people sleep. And in 60% of the women, after 2 or 3 months, they see improvement in their desire, arousal, and orgasm. And so, we try that for the patients, and some patients are willing to pay for it out of pocket. And then we have these as needed, like injectables that on demand. It's called Vyleesi or bremelanotide. It's something that's, we have melanocortins that circulate in our brain, and it's a melanocortin analog. And so basically, you can take this about 45 minutes before intended sexual activity. It lasts a lot longer. So I always say, like, you can take it and then make sure you don't get these side effects like nausea or, flushing or, headaches. And then a few hours later, you might feel some, increased desire to have intercourse. And so I always say, like, that's a good date night drug,
Right. So I tried that about 3 or 4 years ago. It's called PT-141 from a
Right.
compounding
Right.
pharmacy. Yeah. So I tried it because I was struggling and it was just too aggressive for me.
I
I
have
just
patients who tell me that, like, it's just like
yeah.
they feel too tingly all over, like,
Yes.
and, for some people, it's perfect, like, because it
Right.
increases your dopamine, right? So we know it gives you, like, a little dopamine hit or something for a short period of time, and I think for some patients, it works great, but for
Yeah.
other patients, I have heard this, that, like, they just felt like it was a little overwhelming, or, like, they felt tingly all over, or, like, weird sensations, but
But
again, about
what
60% of women will be benefit from that.
why are these two options for premenopausal women? I mean,
Yeah.
it's menopausal and postmenopausal women who are really at risk here.
I know, but, like, low libido with bother is, like, the number one form of sexual dysfunction, even in the premenopausal reproductive age woman. So I think the problem is when you get something FDA approved, like, it's for one indication at a time, and so they
Mhm.
had to choose an indication. I think most of the data at the time was really on, like, premenopausal women, and so
Hmm.
they'll have to go fight to get another indication. It's kinda like about Botox, right? Like, you have indications for Botox. I use it in the pelvic floor all the time for sexual pain issues, and it's not indicated for pelvic floor dysfunction, so it's an off-label use, so it's out of pocket for patients, whereas, like, stuff like migraines and stuff are now indicated for, um, Botox is indicated for that for them, so you could get approval, but it's still hard for
Yeah.
insurance.
I really appreciate you bringing up the brain component here,
Yeah,
where our desire comes into play. But does taking those non-hormonal options also help with, you know, wetness and arousal in our vulva and in our
absolutely.
vestibule?
Right, well, the thing is, like, we always in sexual medicine, we talk about, like, genital arousal and sort of cognitive arousal, right? So,
Yeah.
like, it's like when you're having sex and all you're thinking about is your to-do list. So you're not,
Yeah.
like, mentally aroused, right? But you're, like,
Right.
physically turned on. So there's two components there. But I think that because once you do get that cognitive arousal, as long as you're not really suffering from that genital urinary syndrome menopause and you have, like, the really dry vaginal tissue, then most people will also have an improvement in arousal and orgasm.
Yeah. I can't tell you how many midlife women that I work with in my business who go to the doctor, they finally have the conversation with their OBGYN, they get their estrogen, they get their progesterone, they get their testosterone, but they leave out the vaginal options, the vaginal estrogen. I don't understand how that
Yeah.
one goes is overlooked.
I think one of the issues is that, there's some misunderstanding that if they're on systemic estrogen, then they don't need vaginal estrogen, which I don't find that to be the case. I find that they always usually need the vaginal component as well. I mean, some
Mhm.
people will. I will say that sometimes I have someone that doesn't have significant GSM symptoms, and I'll put them on the systemic stuff because of their vasomotor symptoms or bones or whatever. And they tell me, oh, you know what? I feel a little improvement down there too, and so
Mhm.
you do have some of those patients who will get, some, local, improvement. But the majority of the patients that I have really do need vaginal estrogen or DHEA. And so, and it might, because it's a chronic progressive condition, you may not see it initially, but say you're like, and in perimenopause, you might not see it as much, although I've seen it plenty. It might be like, okay, now you're definitely in menopause and you're 7 years out, and all of a sudden you're feeling all the worst symptoms. So,
Yeah. I want to switch gears a little bit and talk about vaginal rejuvenation techniques. And this is a topic that I've been really searching to find the right provider to talk to. And I feel like you're the one.
okay.
And this topic is just fascinating to me because some women's health advocates say that it shouldn't matter what your vulva looks like. and everyone's beautiful, and you should never consider, altering your how you look down there. And others say that surgery such as something like labiaplasty or vaginoplasty can be quite life-changing for women and their confidence and their sexual pleasure. And I just wanted to get and I want to talk about other rejuvenation therapies, but I want to start here and because everybody's vulva does look different. And there's actually a couple sites you can go to online, and which I'll put in the show notes. I think one is called OMG Yes, or there's I forget the other one, but it
Mhm.
shows pictures of lots of different vulvas, and we all
Mhm.
look different. And
Yeah.
no, there's no one perfect look. Um, and so, what are your thoughts about a woman who's just feeling very self-conscious? Maybe she had a lot of babies, or maybe she was born with, one inner lip, looking different than the other. What are your thoughts?
Yeah. I want to start out first by saying, like, the term vaginal rejuvenation gives me like this cringeworthy, like, I like to, I can talk about each individual thing, but I think vaginal rejuvenation has been really marketed in such a way to really, uh, it's kind of predatory for women, like the way it's done. Like for me, like the best vaginal rejuvenation is vaginal estrogen, right? Like that's really going to
Yeah.
rejuvenate your
Mhm.
vagina. But when we talk about some of these other sort of cosmetic, gynecologic procedures, I'll call them. I do think labia minora reduction or labiaplasties, as they're referred to, have a benefit for a lot of patients. And I've done them in the past. I have patients who really struggle with elongated inner lips. And so you could imagine if the inner lips are really elongated and you're having intercourse and they get stuck in and out every time
Mhm.
they're thrusting, or you're wearing like your tight pants or whatever, and they're hanging out. I have patients who state that it hangs out of their bikinis. Like, how uncomfortable is that
Yep.
for them? And how disruptive is that for their quality of life? Hugely. So I think that, in those scenarios, just to do a good sort of minimal reduction, do think some people take it to an extreme. Like I trained in Ella, and I did a lot of work when I was in Los Angeles, and I lived out there, and they have like a Barbie, that just chop off all the labia minora, and I think that, to me, that's a little aggressive, and you really do worry about sexual function getting
Mhm.
reduced in that capacity, because we all know the little piece, the little nub that you see, that we think is our clitoris. A lot of the arousal tissue actually sits behind the labia minora. And so for
Right.
me as a sexual medicine expert, I kind of get worried that, like, okay, if someone's going to take too much of your labia minora away, you're going to maybe compromise your sexual function or cause sexual pain, right? So there's
Yeah.
always a balance. So I think we have to be very careful in the amount that we remove, and not do anything too drastic. And once you remove it, we can't give it back to you either. So
Right.
to me, I'm not like, if you're gonna try to do that route, and I have plenty of patients, like I said, who have been it's been life transformative for them. Like they found they can feel good about having sex, or have wear the clothes they want to wear. But I think that just the amount and like, and I say we have to do it with informed consent. That has to be what they want, right? Like, I don't know if you saw
Yep. Yeah. Brooke
trending
Shields.
art
Yeah.
about the Shields,
Mhm.
right? And she had
Yep.
a little tightening happen for her
Mhm.
without her consent during her labiaplasty, which is horrible and just unethical. But I think, and there are some people who do have sort of gaping vaginal openings, and for them, it's not even about their significant other. It's really about them not having any sensation during intercourse, and whether or not that would promote that. I don't necessarily do that procedure a lot, but I've seen patients get it done, and have some um, benefit to their sexual function. Again, I would say, like, we have to be wary of the amount and the because you can actually cause sexual pain for some of them as well. So we have to be careful.
Yep. And what about the laser treatments that are out there? There's all different types of laser treatments that promise tightening up of the vaginal canal and the vestibule, even the outer vulva area.
Yeah, and I think again, that whole terminology around it, I think there are some benefits to laser. It's never been shown to be superior to vaginal estrogen, and so I think that's something to remember, or and pelvic floor therapy. But if, for instance, the CO2 laser is something that I even bought into in 2014 initially, and I don't use it that often, but initially I thought, this is way before people were really pushing vaginal estrogen, especially for patients like cancer survivors who they thought would not be good candidates. And so, the thought behind it is if you're using CO2 laser in the vagina, it's just kind of like the resurfacing that's done on your face, that you would stimulate these fibroblasts, which are precursors to collagen, that you stimulate glucose storage, which would increase your normal lactobacillus. And that's what happens in menopause, is that we lose our normal pH because we're losing our normal vaginal microbiome, right? So some of it is stimulated, and I have patients who swear by it and they love it. But it's not been shown to be superior to vaginal estrogen, but we do see some benefits. And there's some certain conditions we think it might help more than others. Like for people, for some vulvar inflammatory conditions, uh, a high potency steroid is really the best thing for it. But there are patients who have not been successful in using the standard treatments. And there's some minimal data to support that it may be beneficial for something like a lichen sclerosis or something, not above the gold standard treatment, but there are patients who have really significant disease. And so there's some data to suggest it might help. And so we know that, and there's some data that show that the CO2 laser did improve the vulvar vestibule, similarly to vaginal estrogen and DHEA. So I think that's important to remember.
Hmm, interesting. Speaking of the vaginal microbiome, how important is it to really make sure that our vaginal microbiome is in optimal health in terms of our sexual function?
I mean, yeah, I mean, I think that's one of the biggest complaints women of all ages come to me for, right, is around their
Mhm.
vaginal discharge and vaginal microbiome. And, we need to have a healthy vaginal microbiome that's full of lactobacillus and acidic bacteria. And so whatever shifts our pH can then change our vaginal microbiome and make us more susceptible to disease, infection, STIs, all the things. And so I think that, it's important. We just, and some people are, really encourage the use of vaginal
Like
probiotics,
suppositories.
probiotics and stuff like that.
Mhm,
And I don't
mhm.
think we have good enough data to support that it helps everybody. I have patients that swear by it. I have patients, and it kind of, we're still learning a lot more about the vaginal microbiome, and this is an ever evolving field. And I think there's going to be a lot that we're going to learn, hopefully in the next few years if we get the data on it. But
Yeah.
I think it's very important.
Well, the vaginal microbiome is a reflection of your gut microbiome, right? So
Yes.
you got to start with your gut microbiome, and hopefully that'll help restore your vaginal microbiome. I mean, there's so many marketing gimmicks out there to help restore, you know, cleanliness and scent, and just these
Yeah.
products being sold to women of all ages. It's just unbelievable
So
to me.
predatory. It's like a
Yeah.
multi-billion dollar industry, this, vaginal hygiene industry, women's hygiene. It's so ridiculous.
Yeah.
Yeah.
Another therapy that I've come across, and I'm sure you have too, is the O shot. So this is that PRP, platelet-rich plasma shot, to
Mhm.
help enhance your clitoral stimulation. What are your thoughts on that and experience with that?
I don't perform that. I again, like I'm part of the International Society for the Study of Women's Sexual Health. We're an evidence-driven society, so I don't think that we have enough evidence to show that it's going to be helpful for women. So I think that, there is a new orgasm process of care that we're going to be in the process of developing that they're going to talk about it actually in 2 weeks at Ishwish. So I think that we're going to have more data on what is beneficial and what is evidence based. I don't think that there's enough evidence to support that, but I have had patients that have gotten it done and they really feel like it's been transformative by increasing. It's kind of like when there used to be like the G shot and all these other things. Like I
Hmm.
think that it may be helpful for some, right? But it's, sex is so complex for women that I think that it's not anything I specifically do, but I have had patients who have gotten it from outside clinicians who, you know, say that it has helped their sexual um, appetite and orgasms and all that stuff. But orgasm dysfunction is very complex, so I think it's important to, peel off all the layers, make sure you're getting pelvic floor therapy and some of the other things that we know will benefit, and then, kind of work from there.
Yeah. Yeah. Enhancing intimacy with sex tools. I like to talk about sex toys as being more of a tool to use.
Yeah.
And we have to build our toolkit. And in our toolkit is possibly menopause hormone therapy. It could be seeing a sex therapist, a pelvic floor therapist. I mean, we have a tool, we have to have a toolbox that's individualized to our needs. But I want you to have you talk about the use of vibrators. There's so many myths out there in using my vibrators. I'm sure you've heard them too. One, that we could get too used to it. We could become numb from using it. We could start to like the vibrator more than our partner's penis if we're in a heterosexual relationship. So what are your thoughts on and strategies for someone listening who might not be comfortable using a vibrator, but we know that as a midlife woman, especially with those nerve endings kind of dulling, that we're going to need a little bit more help revving up the engine.
Yeah, absolutely. I mean, one thing is I think is important to remember is that for some patients, like, intercourse isn't the end all be all, right? Like it's not
Right.
sort of the thing that, and neither is orgasm. Some people enjoy the ride and they don't necessarily need that release. But when it becomes a dysfunction for you where you feel like that things are either not comfortable or you feel like you need help in that because you don't feel good about and you feel frustrated and all the things, then of course we want to work on that. But we've even had some studies to demonstrate that use of vaginal trainers like vibrators, dilators that have vibration, these kind of things are very beneficial for the pelvic floor. And I think that using direct stimulation to the clitoris or to the G zone, as we refer to it now, is very important to really understand. I mean, I have patients that have never used a vibrator and then all of a sudden did, and then realized like, oh, that's what it's supposed to feel like.
Right.
You know what I'm saying? Like they're like, wait. And I think it's again, it goes back to, some of the techniques that sex therapists use, when it comes to sensate focus and even like directed masturbation. Those tools are really important for, improving sexual function. So I'm a big proponent of it. I prescribe them all the time. It's something that I think is very important for midlife women to experiment with.
You just said that you prescribe vibrators. I
Yeah.
love that, right?
Yeah.
Whoever thought that you would have to prescribe a vibrator to one of your patients?
Right. I think it just gives them permission, right? Because then, because
Yeah,
stigma around it is like, oh, I'm going to go to this, like what used to be going to these like, stores like that you would
right.
survive. And now you can get them online. And actually I have some in my office too that I'm going to start like allowing for distribution because I think that if I could just give a patient a vibrator or sell them
Mhm.
one, they would be much happier. Like, oh, my doctor gave me this. It almost gives them permission to
Right.
use it, without feeling like, I'm using a vibrator.
Right, right. Oh, I love that so much.
Yeah.
Um, what are some strategies for someone who's never used a vibrator though? How would you tell that woman to, or prescribe or instruct her to even
Yeah.
start the process if she's never, and also she's also very uncomfortable masturbating, just in general.
Yeah, and I think that that comes along with some of the sex negativity that so many of us hold
Mhm.
from our cultures or our, our upbringing or whatever. I always say start small and start with the less, like not, you're not going to get one of these heavy rabbit, like full dose ones. You want to kind of start small and try to just stimulate the external area. Sometimes doing the vaginal and the insertion is a little bit scary for patients. So we always start with a little bit of clitoral stimulation or and then maybe you move up to something that's a stronger vibration and stronger section. I mean, there's some that actually like you can track on your smartphone, like the Lioness. You can actually see the intensity and all these things it's used for research purposes. So I always, give them a couple options of starting, with the smaller type and then kind of moving forward with it and really doing it in the comfort of their home. Maybe
Yeah.
they're alone one night, no kids, even though husband's out of town, whatever, whoever they're with is out of town, and then watch something or read something that might make them, intrigued or like, get them in the mood. And then if that works, then, just have the vibrator right there and see what happens, So I think that like
Yeah.
you almost have to set it up for yourself. So
Yeah.
you're just not
Today's
gonna
val
stick it
yeah,
on.
we're recording this and it's Valentine's Day.
Oh yeah.
Yeah, I mean, it's not gonna go
These
live
days
then, but
you can have people on
yeah.
speaking
And my
on.
post today was about masturbation, right? And it's something,
Yeah.
yeah, it's just something that I
Yeah.
want to normalize for women. And I was at dinner the other night with my girlfriends. Nobody wants to talk about sex, right?
Yeah.
Nobody wants to talk about even if it's they're having great sex or they found an amazing new vibrator, these are
Yeah.
resources. Let's share
Yeah.
more and have these conversations more with each other.
Absolutely. Absolutely. I'm glad you
Yeah.
did. That's
Yeah.
awesome.
Um, any other holistic approaches for sexual pleasure, including communication with a partner, that you could leave us with before we end our podcast?
Yeah, I mean, I think those are all key ingredients to a fruitful sexual relationship is
Hmm.
really openly communicating. And the one important factor is when you use a vibrator, you know what works for you, right? Like you can, oh,
Yeah,
this is my area of stimulation that when you touch me there, like I'm gonna, that's gonna be it for me. And so I feel like that and then being able to communicate that to your partner and not because then, if it's a male partner, sometimes they get all weird, like, oh, you'd rather use that than, whatever. And I think it's just important because this is why we have an orgasm gap, right? Because we don't communicate with and so I think that, talking to your partner about what turns you on, what doesn't, trying different things, whether it's dress up and play or whatever, or like, planning date nights, those kind of things are really
yeah,
important, right? Like, I think that
yeah,
we have so many patients that are so busy with their life that they don't even have time for it. But if you make time,
right,
like that's good. That's what I tell patients. Like, just plan for that Friday is going to be your sex night. Just like people,
right,
Valentine's Day is one of the biggest days people have sex, right? So it's,
right.
you don't just do it on those special holidays or whatever. I think it's,
Yeah, to me, sex dates are such a game changer. I've been
yeah,
living with my partner for 5 years now. So I'm divorced. I have a new partner in my life, and my kids are all grown and out of the house. Like,
yeah,
any time is good, a good time. We don't have
yeah.
to worry about making lunches or school
Oh,
drop-offs
that's
anymore.
wonderful.
Well, we don't have any of that,
Wonderful.
right?
Yeah,
But we're still busy, and we still
yeah,
have to be mindful, and we still have to plan the time. It's
absolutely.
not like a Hollywood movie where we see each other and it's
I
just
know.
going to happen naturally. Like, it's just not going to happen.
There's
And
not a
also,
plan.
some women prefer it in the morning when they're feeling more awake,
Yeah,
where some men really like it at night, or
yeah,
vice versa. And so
yeah,
I think coming to a common ground, which might be,
absolutely.
2 to 4 in the afternoon on a Saturday or Sunday, is like a
Yeah.
great day.
Yeah, yeah, and compromise, right? Like, I feel like you have
Yes.
to, like, be able to, and that also just goes back to, like, just understanding what your partner's love language is and all the things that will
Yeah.
help to, promote a good, healthy relationship.
I think that this conversation is a great conversation to also have with your 20-something-year-old or your teens that are possibly still living in the house. So I have four
Yeah.
boys and a girl, and I talk about these things all the time. They're between 21 and 30. One of them's
Okay.
even married, and I still have these conversations with them.
Well, good.
It's
Yeah.
really, it's just really important to, like we were saying, normalize it among us and our friends and
Yes.
with our providers.
Yeah,
Normalize it with your children too.
absolutely. I totally agree with you, and I think that's what will help sort of, destigmatize for the next generation,
Yeah,
right? Just really, uh, and I think when you're outspoken about it, then they don't feel the shame around it.
absolutely. Well,
Yeah.
that is a good way to end this conversation. Thank you so much, Dr. Samina. It was so wonderful seeing you. I hope to see you
You
in
too.
person again. And anything coming down the pipeline for women's sexual health that you want to just end with?
Oh, yeah, I mean, I think, this in April, there's gonna be in Chicago, at least, there's gonna be an M factor screening, that
Oh,
I'm gonna
great.
be involved in, and I think that, there might be some events around that week. I can't remember if it's, like, April 8th or I can't one of those. You can I'll
Okay.
let you know, and you can post it in your show notes maybe. But there's
Okay.
gonna be some, some events coming up, and I think hopefully in the summer, we'll be able to do some stuff too. I have a book, that I'm working on, about sexual wellness specifically from a South Asian perspective, and so I'm going to be incorporating a lot of cultural and religious aspects that impact sexual function as well. But it's great for everyone. But I think that like from the lens that I'm looking at, it will incorporate things that are not usually incorporated into most books.
Oh, that's wonderful. Congratulations on that. And you also have an amazing podcast that I tune into all the time.
Well, thank you so much. I appreciate it.
Yeah. So I'll
Um,
put all of your contact information in the show notes so people can find you.
Perfect. Thank you, Jill. Appreciate you.
Yeah. Well, thanks for joining us today. And thanks everyone for tuning in.
Thanks, guys. Take care.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.